running a little bit late, so I'm going to kind of jump in now. Sorry for the sort of miasma of doom and anxiety today. We'll try to work through it. We're going to be talking about seizures today, which is probably the #1 thing that brings our kids into you guys in the hospital. And we'll start off talking a little bit about, just in general, febrile seizures, non-febrile seizures, and what to kind of think of whenever they're in the hospital. But the majority of the time is going to be on common childhood epilepsies, because these are things that you will frequently see if you're a general pediatrician. You're going to see this in the community. And if you're working in the hospital, you're going to be seeing our patients a lot. Okay. So febrile seizures are the most common neurologic disorders of infants and young children. I think you guys get plenty of these. For the most part, the emergency department deals with them without ever really calling us, unless the kids are kind of outliers and we're dealing with like a complex febrile seizure. So incredibly common. And if it's associated with fever in children 6 months to 60 months and it's not complex, we typically just kind of watch and give the family reassurance and maybe a prescription of Diastat. So complex febrile seizures, though, can be indicative of a little bit more trouble. So in general, a simple febrile seizure only has a very minute increase in the risk for epilepsy later on. With complex febrile seizures, that increases quite a bit. And if the febrile seizure shows any signs of focality, one of the things that makes it complex, then we really need to investigate that further in and of itself, and generally we end up having to get imaging for that. So, as far as evaluation, unless you think the kid's sick, otherwise, there's no reason to really get labs for febrile seizure. LP only if there's concern for meningitis or encephalitis, or if you have these young kids that are under 6 months of age, particularly the really tiny ones showing up with fever. You may do that as part of the fever workup. EEG is generally not needed for a simple febrile seizure unless it is complicated in some way. And so a complex febrile seizure, guys, I think you're familiar with this, but it lasts longer than 5 minutes. It shows focal signs. So things that are kind of making us think, oh, something else is going on. Yeah. And or you have more than one episode within 24 hours. That's probably the one we see the most often. And this just in general, it increases your risk of epilepsy later on. And it makes you think, oh, maybe something else is going on. So generally, unless it's a complex febrile seizure, we don't get. Imaging isn't required unless you're worried about, something else, abnormal features, large head, you're worried about increased intracranial pressure, something that makes you think there's a mass, something along those lines. Or if there are really strong focal features with the EEG or with the clinical seizure itself. Non-emergent MRIs can be helpful and generally give us more detail than the CTs. I think you guys are already familiar with that pretty much. So treatment-wise, we don't treat with febrile seizures. So the one thing we can give is rescue medication, so sending the family home with Diastat in case they have a prolonged seizure. Stressing, don't give this unless it lasts longer than 3 to 5 minutes. And that gives the family some reassurance. But there's been quite a few studies looking at use of antipyretics. And regardless of how much the family chases it, there's really no evidence that stops it from happening. Giving kids prophylactic medication for febrile seizures, like a daily anti-epileptic drug, is discouraged because they do have side effects. And there's no evidence that it helps longer on, like down the road. It doesn't seem to decrease the likelihood of evolving into any sort of epilepsy. And sometimes whenever kids are having really frequent febrile seizures that are really, really long, we'll send the family home with some benzos and tell them, well, when the kid starts having the fever, start taking these benzos and just kind of ride them through. But that would be only in really severe cases. So Your risk for subsequent epilepsy, this is very testable. With a simple febrile seizure, it's like 1 to 2% increase. With the complex febrile seizures, you're looking more at like 5 to 10%. So that's one of the reasons that we really do mark those kids out, because it means something very different from a simple febrile seizure. And what is probably going on is that this is simply the epilepsy asserting itself early because the kid's sick. So first, non-febrile seizures. History is really going to help you determine whether or not it's a seizure. Spells are one of the primary things we see. Is it seizure? Is it syncope? A orthostatic syncope, what's going on? There are some things that really can clue you into the fact that this might be a convulsive seizure. The description of the event itself, how the family described the movements. If there's any evidence of oral trauma, like biting the tongue, particularly the side of the tongue, that really fits with it. Any evidence of incontinence. Sometimes nausea and vomiting can be a really strong component of the seizure itself. And what did the eyes and the mouth do? If a child closes their eyes, that doesn't mean that it can't be a seizure, but more often than not, when a child's having a convulsive seizure, the eyes are open and they kind of roll back. You can also have deviation over to the side, so all of that would make us think a little bit longer. And then, does it have a post-signal phase? So if a kid's having a convulsive seizure that lasts 5 minutes, afterwards they should be completely wiped out. If they're not, you're going to think, something's going on other than a convulsive seizure, more than likely. So all of these are important, and if you can get a video, that's great. So helpful. Of course, that's the last thing on a parent's mind whenever a child does something like this for the first time. So as far as workup, again, the workup is going to be very individualized. So, if you think the kid is vomiting, having diarrhea, they might have electrolyte instability that may be contributing to it. We definitely need to look into that. If you think there's some possible exposure, testing toxicology can be important. You can potentially look for infectious causes, but this is going to be very much individualized depending on the kid. Honestly, I wouldn't worry too much about CPK. And also, the lactate research is really questionable. I'd just kind of hold off that and let us deal with that side of things. An LP generally is not indicated as a workup unless you're worried about meningitis or encephalitis because of other symptoms the child's having. An EEG can be very helpful, but there are a few things to know. If the kid gets hammered with benzos on the way over, the EEG is going to be less useful because we've treated seizures, Also, many times the EEGs do normalize a bit after a seizure. It's kind of like the brain resets. So that doesn't mean that it's not going to be valuable to get an EEG, but what we may end up doing is if we get an EEG there and it's normal, end up having them follow up with us in a couple of weeks, get one as an outpatient. It's probably going to be higher yield. So hyperventilation and IPS are helpful depending on the kid's age and what the family is complaining of. As far as, the semiology of the seizures, imaging can be helpful. Again, unless you absolutely have to, because you're worried about a mass or increased intracranial pressure, try to hold off and get an MRI. It's going to be a lot more useful to us. Clearly, if the kid's tanking or you're worried about increased intracranial pressure, a mass, whatever, get the CT. But if you're not super concerned, hold off for a little bit. So as far as treatment, a lot of times we don't treat after a first non-convulsive seizure, a first non-febrile seizure. If the EEG is abnormal, sometimes that really pushes our hand because we may look at it and say, oh, wow, this really looks dangerous. Other times, even if it's abnormal, we'll say, oh, well, this looks like benign Rolandic epilepsy, and discuss the risk of them having further seizures. And do they want to medicate now, or would they prefer to hold off and see if there's another seizure? And then generally, if we've decided the child has had a seizure, though, you're going to send the family home with diastat and instructions on how to properly administer first aid once the child is having seizures, and then have them follow up with us, because Many kids, the majority of kids who have one seizure do not have further seizures, but a fairly good portion of them do. Enough that we want to keep in touch and make sure they know how to follow up with us. So whenever kids show up that are known to neurology and being treated, definitely look at the outpatient notes. I know sometimes this can be difficult as far as the ED goes, but take a look, see what they're treated with, see if they've been admitted for something similar before. Check therapeutic levels on anti-epileptic medications. The number one reason for a child with epilepsy that's well controlled having breakthrough seizures is they've stopped taking their medication, particularly in adolescence. So checking that, and then talking with the family about possible triggers. And if they're on monotherapy, try to increase the dose by a little bit. And if they're on 2 or more drugs, sometimes we actually mention in our notes what we do if they have an additional seizure, but look at the recommended dosing range, look at the outpatient notes, what we're kind of working towards, and modify according to that. Generally, at this point, the emergency department or the community physicians have reached out to us, and we can give a little bit further advice because we are willing to push medications a little bit further than the recommended range many times.
Level, because you know, parents are like, well, I mean, we missed last night, and obviously, you know, then when the level's super low,
yeah.
But like, when would you expect to see that tapered in on?
So it's going to depend based on the half-life of the individual medication. Yeah, so with Keppra, if you're off of it for about 2 days, you're going to have definitely low levels. Yeah, you're going to be in trouble at that point. Some of the other medications like Oxcarb, it's going to be in the system forever, you know. So if it's low, either we're not dosing adequately or they're not taking it. Lamictal is another one that just hangs around forever. So of course, by the time you get the level back, they're going to have been discharged, even if they're in the hospital for a week. But the levels just don't budge. You know, you can skip days and not have a huge impact. All right. And then EEG, continuous video EEG gives us a lot of information. One of the major reasons we use it nowadays is in kids in the ICU that we really don't have a good exam on if we're concerned in any way about non-convulsive status epilepticus. We definitely need to get that on board. There are other times that if we have the machines available, we like to hook it up when a kid comes in with a first-time seizure, just to kind of see, can we get some information that will help guide us as far as likelihood of further seizures, you know, what information we can give the family about the type of seizure, that sort of thing. But the major emergencies are when we're not sure if the kid is still seizing, or we're trying to really characterize something and it's going to affect treatment. And as far as abortive seizure plans, if they're in the hospital, the abortive plan has clearly failed. If they're not using the medication, then really trying to stress to the family, take the medication, take the medication. If it's simply that the medication isn't working, then we need to come up with a different plan, either increasing the dosage of the medication or revisiting what medications we're using and maybe trying to add something else on, ultimately switch over to something else. So now our common childhood epilepsies. So we have a 10-week-old male infant, full term, no complications. And then they start seeing some spells. So the kid's having spells with right head deviation, right arm extension. It progresses to bilateral limb extension and trunk flexion. This happens several times a day. And they're noticing that the kid isn't as active as it used to be. It's not feeding as well. So you get an EEG, and this is what it shows. Anybody want to venture a guess as to what might be going on? So we've got a burst suppression pattern. What was it? That's what everybody thinks, but based on the age and on the EEG, that's not actually what's going on. So you're seeing a burst suppression pattern. This is essentially what you're going to see if you lug someone with massive amounts of you can also see this with really high levels of brain injury. You are also going to see a very similar pattern in very premature infants. But in this case, if you see a high amplitude burst suppression pattern in a relatively young infant in the first months of life, what you're going to think of is Ohtahara syndrome. And so Ohtahara is one of the early infantile encephalopathies. Sometimes it can progress to infantile spasms, but that's a bit different. It tends to have a really, really bad outcome. Kids can have multiple different types of seizures. Most of the time they can have, they have these spasm type events, so tonic spasms, and they can look different ways. You can have tonic extension, tonic flexion. You can also have partial seizures, myoclonic seizures. They tend to be pretty hard to control. And many times when we do imaging, we find these kids have underlying structural abnormalities, hemimegalencephaly, schizencephaly, things like that. We have a kid in the NICU right now that has been basically seizing nonstop since birth and is now like at least 2 months old, probably going on 3. And it looks like he's got this, or a variant of it in any case. So it's really bad, really hard to control. You're going to throw multiple meds at them and kind of do what you can. If they have hemimegalencephaly or some other finding on imaging that seems resectable, these are kids that can sometimes really benefit and do really well with neurosurgery. So if it's hemimegalencephaly, you actually take out that bad side of the cortex. And sometimes I've seen kids do just wonderfully. As far as medications go, phenobarbital with babies, they're always going to be on that. We end up using Keppra a lot because that ends up not really affecting hemodynamics, and particularly like in the ICU, it's good because it's not going to interfere with other drug levels. Clobazam has become a big favorite. Vigabatrin is really highly used, and then we just keep adding on and adding on and adding on. And honestly, generally we never get it under full control. One thing to know about this, although Ohtahara syndrome has some similarities clinically to infantile spasms, and sometimes it can turn into it, there's no evidence that ACTH actually helps with this. So if a child has Ohtahara syndrome, we definitely need to be watching them, but at this point, they do not have infantile spasms, and so the ACTH is not going to help. And this I won't stress too much. Just suffice it to say there are other neonatal encephalopathies. So a 12-year-old girl has a first generalized tonic-clonic seizure one morning while watching cartoons. You talk to her and she says, you know, I have this problem where my arms jerk and I drop things in the morning. Anybody have any ideas? This is the classic story for juvenile myoclonic epilepsy. The other one is you're studying for a test and it happens. So with juvenile myoclonic epilepsy, if you're tested on an EEG for that, 4 to 6 hertz polyspike and wave. So a fast spike wave that's faster than your 3 hertz you see with absence, and you see polyspikes in it. In reality, kids with JME can have absence seizures and they look just like the other absence seizures, 3 hertz. You won't be tested on something like that. So if you see polyspike and wave and it's fast, JME. So juvenile myoclonic epilepsy, unlike a lot of the other childhood epilepsies, is not something you're going to outgrow. About 90% of people continue having seizures into adulthood if they stop medication. So it's important whenever counseling people to really stress that this is something that's going to have to be taken seriously long term. As you would guess from the name, myoclonic seizures are a really prominent portion of this epilepsy. Almost never do people come in simply because of that, though. Generally, you have like around a 2 to 3 year history of someone having had myoclonic seizures before they have the convulsive episode that brings them in. Occasionally, I've had people come in with absence seizures with this, but I have yet to have, well, I had one case where a child came in with myoclonus, and it was before she had had any seizures. But almost all of them have a history once you ask. So with juvenile myoclonic epilepsy, in addition to the myoclonic seizures, you can have generalized tonic-clonic seizures. That's generally what brings the kids in. They can have absence seizures. One thing to know, they are very susceptible to flashing lights often. This is one of the few epilepsies where that is the case. And they are highly susceptible to sleep deprivation. So these are kids that lifestyle is even more important in controlling seizures. I had a kid who rode crew, really loved it. And just because of the lifestyle factors with it, we had to really press her to stop it because she couldn't get to bed early enough to get 8 to 9 hours of sleep and wake up at 4:30 for her crew. So I tried to convince her to do afternoon rowing. I don't think that's working, but so definitely be aware of that. As far as the clinical course, like we said, generally this is lifelong. And generally, the kids have been having myoclonic seizures for quite a while before they have this full-blown GTC. So on a test, if they ask you about treatment, it's going to be valproate. Clearly, we don't like using valproate, Depakote, particularly with girls. Lamotrigine is probably our best drug. Unfortunately, due to Stevens-Johnson syndrome, it takes about 3 months to get up on a good dosage of it. So oftentimes what we'll try to do is start with Keppra, see if things are under control. If Keppra works great and is controlling everything, fine. If they're having side effects from it, or if it's just not fully cutting it, then we try starting the Lamictal and just adding that on. Be aware that Lamictal can sometimes increase myoclonic seizures. If that's the issue, we just try a different drug. Many times it isn't a concern, but every now and then you will have a kid where everything seems to be going along okay. We put them on Lamictal and the myoclonic jerks just become really severe. So the answer on the test would be Depakote. Yeah. And if they're looking for something else, they will specify that it is a female. My guess is that they're going to say it's a male and it's going to be Depakote. Yeah, go up slowly. It takes about 3 months to go up slowly. But by creeping up, if you look, there are some instructions on faster titration. I don't do it simply because Stevens-Johnson is a really nasty thing. And if you creep up on it, it is rarely an issue. So our third vignette, you have a 7-year-old boy who's having episodes of gurgling and drooling at night. When he's trying to fall asleep, he'll get his parents during it, or the parents will come in and see him, and he's trying to speak to them. So he's awake and responsive, but he can't. And his right face seems to be pulled and twitchy. And once he had a seizure like this, and it spread to his full body, and he had like a secondary generalization with convulsions. During these seizures, he reports feeling an electric shock around his jaw. And so this EEG has increased spikes during drowsiness and sleep, and they're in the central and temporal region. And so he has benign epilepsy with central temporal spikes, or benign Rolandic epilepsy. So it generally starts in young school-age kids. It generally lasts a few years. It generally goes away. Most of the time, it stops being an issue well before the whole driver's license concern. So these are partial seizures, you can imagine, since they're coming from the central temporal region, but may generalize. They typically occur at night. Occasionally, they can occur during the day. One of the interesting factors about them is that they tend to have the slow spread. So oftentimes the kids retain consciousness throughout, or if it generalizes, are at least awake during the early part, which means sometimes they can be really traumatized by these because they have memories of trying to talk to their parents and not being able to, of having these strange sensations. And it certainly, if a child is having stress with that, we'd be more aggressive about treating, even if it's not secondarily generalizing. So this is an autosomal dominant disorder, but there is variable penetrance, so there may not be an apparent family history. Course is very, very variable. A few have only one seizure, never a problem again. But 20% have very frequent seizures. And so many times whenever kids come in, if they've only had one or two, we discuss it with the family. And if they're really adamant that they want to be on medication, I'll start them on something relatively benign like Keppra or oxcarbazepine. But if they're kind of wary about medication, we say, okay, you have diastat to use if it's a longer seizure. Let's see how frequent these are going to be, you know. And sometimes it's simply not an issue. Other times they're having them often enough, or they're stressing the child out enough that we go to treatment. On a test, the answer for this is going to be either carbamazepine or oxcarbazepine, depending on how out of date the testing material is. Sometimes we use Keppra, which is pretty effective. Sometimes we use zonisamide. The others less often. Occasionally, historically, there have been some people who have treated with benzos at night, and that's going to interrupt their sleep cycle. You know, they're not going to get as effective sleep. I wouldn't recommend that as a first go. I think you'd be better if you're starting something to start one of the focal epilepsy drugs. So clinical vignette 4, let's see what we're doing for time. So clinical vignette 4, we have a 4-year-old girl who has episodes where she stops what she's doing, stares off, and then goes right back to whatever she's doing. They occur many, many times during the day. And her teacher has noticed these, and she's also reporting increased inattention in class. Her grades are kind of going downhill. And what do we see here? Yes, this is absence. This is a 3 Hertz spike wave. And this is totally, totally fair game for a test. If you see really nice machine-like EEG spikes, try to count them out if you can. If it's anything close to 3 Hertz spike wave and it looks really nice and tight and machine-like, that's your answer. So childhood absence epilepsy, incredibly common. There's also a juvenile absence epilepsy that starts a little bit later, is a little more severe. With these kids, they're having multiple seizures a day, on the order of tens or hundreds. And they're generally pretty brief. So lasting, 10, maybe 15 seconds, 20 seconds. If they're lasting like a full minute, you're probably thinking more like a partial onset seizure. So with focal epilepsies that have partial onset, you have staring spells that are less frequent but last longer. With childhood absence epilepsies, you have brief episodes, but many of them. And it is not uncommon for kids to have hundreds and hundreds a day. Of course, the more likely there is to be severe impairment. They're sensitive to hyperventilation. So you can test for this in your office. If you've got a pinwheel, make the kid blow, blow, blow for 2 or 3 minutes. If you can provoke a staring spell, you've got your answer right there without even getting an EEG. And otherwise, the kids are fine in between the episodes. So if they're only having relatively infrequent seizures, it's not common for there to be a huge amount of it's not uncommon for the kids to not have really a huge amount of disability. For the kids who are having hundreds a day, you can imagine their brains just are not functioning. They're not taking anything in because everything is just little bits. The thought was classically that it had to be 10 seconds long to be a full seizure. We've since been able to do research where you give kids stimuli during these bursts, or actually adults, give them stimuli and test. And if it's 3 to 4 seconds long, you're going to have a clinical deficit. It's just they're back afterwards. They don't have this post-ictal. And so it isn't apparent. But if you're driving and you have an absence seizure, for those few seconds, you're not taking in information. So the EEG, many times we're not able to capture a full seizure, but many times they still give us a hint on EEG. You have these brief bursts of 3 Hertz spike and waves. If you get a full seizure, it's going to be a longer burst. And it is going to be, it can be triggered by the hyperventilation. That's the first place we look whenever we're reading an EEG for a kid that we're concerned about this. Treatment, test-wise, ethosuximide. I'm not a huge fan of ethosuximide. It makes kids sick. It can make them sedated. Generally, I start off with Keppra or Lamictal. The other thing is that ethosuximide only covers absent seizures. So if the kid is coming in with a history of any convulsive seizures, at least be aware that the ethosuximide isn't going to cover that. So lamotrigine and Keppra will. So oftentimes I like that because if they're simply having staring spells, it isn't really just a full-on neurological emergency. So unless they're failing in school, you can go up gradually with Lamictal, see how it's helping, and it tends to be tolerated much better. Sometimes Lamictal doesn't work, sometimes Keppra doesn't work, and then I'll try ethosuximide. And sometimes it can be very, very effective, but it has a kind of nasty side effect profile. Don't use your focal anti-seizure medications with these kids. And as is generally the case, our goal is to treat for 2 years, seizure-free. When we take a look at the EEG, if the EEG looks normal, we can go down gradually on the seizure medication. So, clinical vignette number 5. And if you guys have questions, just let me know. So clinical vignette 5, we have a 4-year-old boy with global developmental delays. And he has a history of seizures, but they come in because he's having new types of spells where his head drops, and sometimes he'll become very stiff. Sometimes he'll fall over with it and can really hurt himself badly. He's having worsening behaviors, and sometimes he'll stare off for a minute at a time. He seems confused afterwards. Then he develops convulsive status epilepticus and comes into the emergency department. And so this is our Lennox-Gastaut. And I don't think you'd be tested on the EEG for this, but it's a slow, poorly organized background with slower than absent spike wave pattern. And if they have absent seizures, you'll see that typical 3 Hz spike wave activity or possibly slower. If they have a tonic seizure, you can sometimes see electrodecrement with it. You're not going to be tested on that. What you do need to know is that these are kids with really hard to control seizures. They often have, almost always have a developmental delay. These are kids that oftentimes are infantile spasm kids and evolve into them. They have really frequent seizures. The ones you're most familiar with are the generalized tonic-clonic seizures, but actually the tonic and atonic seizures are the ones that are the real problem with these kids because they can fall and they can fall hard. Most of the time when people are having drop attacks, if it's due to like orthostatic syncope, you go limp and that protects you a little bit. With these kids, particularly if they're having the tonic seizure where they go rigid, they smash into the ground and they really can injure themselves badly. Just, it's unbelievable. So these are kids that often end up with those soft helmets, and we can even end up doing neurosurgeries that we would not in any other situation do. So treatment-wise, it's hard to treat. You're going to throw everything you can at them. All of the newer drugs are approved for this. So Onfi is approved for this. Epidiolex is approved for this. You're going to use whatever you can. They're not going to be candidates for focal epilepsy surgery, but they can have a vagal nerve stimulator. And sometimes we even do corpus callosotomies where you kind of split the brain. And that is not a minor surgery by any means. This is for the drop attacks if they are just destroying themselves with them and we can't get it under control. Sometimes diet can be an option. So sometimes we send these kids to keto clinic. Often they're G-tube fed, and G-tube works well with keto because it's a really gross diet. It's like a mega Atkins diet. So basically the kids are eating nothing but like mayo all day long. So, so our next clinical vignette, we have an 8-month-old boy who is developing clusters of spasms. Sudden forward flexion of the head and neck, flexion of the arms, but it could be other ways as well. His mother thought he was having abdominal cramps. She changed the formula, that didn't help. And what do we see here? Exactly, hips arrhythmia. So many times we send kids in because they're having spasms. And that's exactly what we're looking for. So hypsarrhythmia, the name gives it away. High amplitude chaos. It's just a huge mess. There's no discernible background. You're seeing spikes all over the place. Everything is just massive amplitude peaks, and there's just no normal background. The great thing, if there's something about it, this is not the seizure. This is the background just on your standard given minute, you know? So if you can hook this kid up to an EEG, if you can get 5 minutes of recording, you can tell whether or not the child's having infantile spasms. So get them hooked up to the EEG, see what it shows. And, you know, if it is an infantile spasms, well, we can at least take a deep breath, and may still be seizures. There, you can have other types of tonic spasms, but we're not dealing with infantile spasms. This is the interictal background. Actually, during a seizure, it can briefly look normal because the kind of drops down and you have some semi-rhythmic looking activity. It's called pseudo-normalization. So with infantile spasms, as opposed to Odahara syndrome, which happens in the first couple of months of life, infantile spasms is a little bit later. So 4, 6, 8 months of age is where you're primarily going to see it. Occasionally, you can see it after a year of age. These spasms are exactly what they sound like, tonic spasms. They tend to be symmetric. Sometimes they can be stimulus-induced. Sometimes they're associated with falling asleep or waking up. You can sometimes see other types of seizures with it as well. So if you have the triad of infantile spasms, mental retardation, and hypsarrhythmia, you have West syndrome. And even if you don't treat, hypsarrhythmia eventually goes away, but it burns out, which is not a good thing. And these kids are at very high risk of developing Lennox-Gastaut, which we just talked about earlier. Many times, the child had a rough beginning. Not always. Sometimes there's nothing clear. One thing to be aware of, if the child seems to have had a completely perfect existence up until this point, tuberous sclerosis is one of the major causes of infantile spasms, and you treat it a little bit differently. So you're going to start vigabatrin much earlier with that. So that's just something to think about, because sometimes kids with tuberous sclerosis can present with seizures first. So the treatment with infantile spasms is ACTH. I don't know if any of you were on service a couple of months back when we had that kid with infantile spasms. Insurance would not approve the ACTH. And so we were fighting, but it was a weekend and we couldn't get anything done over the weekend. So we started high dose steroids, which, if you think about it, is kind of the same pathway as the ACTH. The data is much stronger for ACTH, but steroids are okay if you have nothing else. So it's not that steroids don't work, it's just that they're not as effective. So if you're ever trapped in that situation again, or you're somehow in a situation you're treating in the wilds of Alaska and you can't get ACTH, high dose steroids until you can. And then generally what we do is we treat the kids, we watch to see how they're doing, we recheck the EEG in about 2 weeks' time. If they're doing better, then we can talk about starting to wean off and see how they do. If they're not doing better, we can try a higher dose of ACTH sometimes, or we can try adding on other medications. Sometimes kids do pretty well. For the most part, these are kids that you're going to see again, unfortunately. But every now and then we have a kid who does great. We never, we see them in follow-up and everything's going great. So clinical vignette 7, we have a 5-year-old boy who presents after several weeks after having a single convulsive seizure. He was developing normal until the seizures, but since then, the family noticed his speech becomes less clear. He doesn't seem to be hearing them when they speak to him. And he's not responding to any verbal commands. Unfortunately, he doesn't get a diagnosis at that time. 6 months later, he's completely mute and doesn't seem to respond to outside stimuli, auditory stimuli. Hearing was tested and was normal. He's becoming more aggressive. And you get an EEG. And the waking EEG looks pretty normal. And drowsiness, you start seeing something. And then in non-REM sleep, you're seeing just basically continuous seizure activity. So this is Landau-Kleffner syndrome. Tests love this because it's associated with an acquired aphasia. And the aphasia is felt to be due to an auditory agnosia. So the kids are hearing it. They just can't interpret those signals correctly within their brain. So they hear the noise, but the noise makes no sense. And that is thought to be, at least in part, related to behavioral disorder. Where a lot of confusion exists is how does the EEG tie into the auditory agnosia, and what is the connection between the seizures and the auditory agnosia? So we, of course, try to treat the seizures as best we can. They can be kind of hard to treat, but even if you get the seizures under good control, even if the EEG during non-REM sleep starts to look better, the kids may have continued auditory agnosia. They may still have behavioral disorders as well. So it seems like these are coming from a core cause rather than it being symptomatic of the epilepsy itself. But it's always something to keep in mind if you've got a kid that is coming in with mutism and just doesn't seem to be responding well, you're worried about autism, that sort of thing. The challenge is that you've got to get an EEG with sleep. Not necessarily, to the degree that you can test for such things. So there does seem to be potentially some behavioral issues that come before, but who's to say they're not having milder symptoms? Who knows? Yeah. And then the seizures are kind of on their own separate path, and so you're going to want to be treating on both sides aggressively. So behavioral therapy, developmental peds, and also working with seizure control. Benzos tend to work really well with this. Clobazam is probably our first go-to medication. We often end up throwing on other things. Don't use phenobarbital and don't use the focal seizure medications. They can cause problems, but pretty much anything else is fair game. And so this is just talking about, sort of the interrelatedness or lack of interrelatedness between the auditory agnosia and the EEG and seizures. And basically, is that you can separate the two out. So there seems to be some sort of root cause. And we are at 106, so we can probably make one more. So clinical vignette 8, we've got a 7-year-old boy. He's had about 12 episodes of collapse at school over the past year. All episodes were stereotyped, but rather long. Some of them lasted up to 35 minutes. And when they occur, if he's standing or sitting, he slumps forward and falls forward on the desk or onto the floor, becomes unresponsive. Nobody can wake him up. This can last forever, but he's not convulsing. There's nothing really ictally that seems to be going on. He's just out of it. And then afterwards, he kind of bounces back to his normal self. And many, many times throws up. So what you're seeing here are occipital spikes, and this is Paniatopoulos syndrome. So the reason it's good to know Paniatopoulos syndrome, I doubt you're going to be tested on this one, but I'm throwing it in because these seizures tend to be weird. You can go into autonomic status, which is what this kid has lying on the floor, unresponsive. So you can have really weird presenting factors. Very often there's vomiting that occurs with it. And you can have like sweating. It's a really interesting syndrome with really interesting seizures, and they tend to last a long, long time. So you would think with these really long, horrible seizures that this would be just a really bad disorder to have, but they do great. Clearly, if they're having autonomic status, you want to be able to treat it. So certainly send them home with diastat, but they have normal development. The EEG typically shows occipital spikes. In real life, it can show pretty much anything, including normal. These kids respond well to focal anti-seizure medications or our broad umbrella seizure medications. However, a huge proportion of them only have one seizure ever. And the majority of them only have a few. So sometimes the families will decide they just want diastat. You tend to outgrow it within 2 years, and remission is full. So there doesn't appear to be any long-term deleterious effects. Occasionally, these kids will evolve into benign Rolandic epilepsy, but that also goes away. They do not seem to be at any increased risk compared to the general population for developing epilepsy as an adult, which is kind of interesting. So, all right, that's our slew of seizures. Does anybody have any questions?
Besides the juvenile epilepsy, is there any other disorders that get worse with like sleep?
Many times sleep deprivation can be a trigger, but it's going to be variable and kind of patient dependent. So illness is never a good thing for seizure control. Fatigue is never a good thing. Stress is never a good thing. But the degree to which it's an effect can vary. And what we see with juvenile myoclonic epilepsy is we can have kids under great control. And if they just get 6 hours of sleep, they can end up having seizures, you know? Like they don't have to be super sleep deprived. So these are kids that you really do have to stress. You can't pull an all-nighter, you know. I would be very wary of sending a kid to a sleepover. You know, they have to get good sleep. But not getting good sleep is not a good thing for any of these. The ones that you're most likely to be tested on, infantile spasms, they love that. ACTH, hips arrhythmia. Absent seizures, they love that. 3 Hertz spike and wave, looks like a machine. Simply because it's complicated, you're not going to have to know the EEG associated with it, but Lennox-Gastaut, multiple seizure types, including drop seizures, generally having to use multiple different types of medications. And then the other one that's probably the highest yield is benign Rolandic epilepsy, which is the one that happens mostly during sleep. The kids can have focal seizures where they don't lose consciousness, and they typically outgrow it. So I think those are the ones that you're most likely to be tested on. All right, well, thank you guys for your attention. And we will see you on the wards.